Thank you, Glenn. Can everybody hear me? Good morning, everybody. I'm so glad we haven't got those orange ties in government, by the way. Otherwise, that means we've got a coalition government and nothing would be happening for these next few weeks. But it's really good to see that what Jeremy Hunt was saying there, that it really is full steam ahead now. I'm going to spend about half an hour. I wonder if we could change the rules as well about the question and answer session. Can I get to throw the box? It depends on the questions, of course. I want to spend the next kind of half an hour, as Glenn said, just bringing you up to date on what has been happening in government in the last few weeks. I equally didn't write my slides of my presentation until yesterday because things have been moving at a pretty rapid rate over the last couple of weeks. I hope in the next half an hour that I can stress how important GS1 now has suddenly become. We always said it's important. We always said it's imperative in terms of patient safety and efficiency. But hopefully over the next half an hour you'll see that it's not just a good thing to do. It's actually going to be essential in terms of delivering some of the efficiencies that NHS needs to deliver over the next 5 years. So what do I press here? Is this one here, is it? Okay, and just to remind ourselves of the efficiency challenge, and I'm sure every single person in this room is very aware of this, but it's real. Simon Stevens, in his 5-year forward view last year, put a marker in the ground, I guess, about the real challenge that the NHS is facing over the next 5 years. He didn't know back then what an incoming government would invest in the health system over those 5 years. As it happens, the Tories pledged that they will put 8 billion in, and sure enough, they've pledged that they will do that. I'm not quite sure when it comes in, by the way. It might be in 2019-20. But on top of that, there's still a huge efficiency gap looming. Simon calculated it to be 22 billion. I've seen various numbers in recent weeks that are around about that number. I've seen 19, I've seen 20, I've seen 22, so give or take a billion. It's around about 20 billion. But the real key thing about this is that this means that every single trust in the NHS over the next 5 years is being asked to deliver 2 to 3% efficiency savings year on year. And when you consider the average efficiency for most of the NHS history for hospitals has been about 0.8%, albeit it has risen in the last 4 or 5 years to 1.5% to 2%, but that's largely been down to pay restraint. It gives you a bit of a sense of the enormous challenge that trusts are facing now in delivering these efficiencies. And as you've just heard, so it was a nice lead-in, thank you, Glenn. Efficiency has suddenly become really, really important to the Secretary of State. And I'm sure you've been following the press over the last few days, following Secretary of State's speech at the Confederation. And there were various things in the press over the weekend. Some interesting views and some interesting comments, not all of which have actually come from the Carter report, and I'll explain that a bit later on. But at the heart of this is the notion that actually we really need to get on with this efficiency agenda, and a view that the work that Lord Carter has been doing is essential to that end. And I'm going to spend the next 10-15 minutes explaining what the Carter work is, what he's saying, what needs to be done. The thing that I will say is what tends to happen in any spending round when any new government comes in, and it kind of happened, I guess, with the 20 billion challenge of David Nicholson with the QUIP agenda some years ago. You start with a number up there, and then you kind of work down from it how the efficiencies can be delivered in the NHS, not knowing really whether those are real or whether they can be delivered. What I will say about the work that Lord Carter's been doing, it's been done the other way around. It's been done from the ground up, assessing, looking at data, looking at differences, looking at information, to truly establish what it is that could be delivered in terms of efficiency over the next 4 or 5 years. That's him, if you've never seen him. His report, I believe, will be out on Thursday, I was told yesterday. So it will be in the public domain on Thursday. And it will contain a number of things. The first thing I want to say is that when he first started looking at efficiency in the NHS, the first question he asked was, do we have a means of measuring relative efficiency trust by trust? Do we have a means of comparing one trust with another in how they are efficient or not? And of course, he knew there wasn't. And most health systems around the world do have a means of measuring efficiency. In America, although that's not the only country we've been looking at over the last few months, in America they've had a thing called adjusted admissions for something like 40, 50 years. The hospital chains, hospital groups use to measure the relative efficiency of their hospital units. And basically what it is, it's just a means of measuring outputs and weighting them for case mix and so forth. And the idea is then you can use that kind of base metric, that denominator, to apply it to anything else, any kind of number across your health system to get a relative comparison of hospital to hospital. More importantly, though, it also gets used to become a baseline for each hospital, so they can see their own year-on-year, month-on-month improvements in terms of efficiency. So it's also a means of measuring improvement. We, for the last 3 or 4 months in the department, have been working with Lord Carter to develop such a measure. It's going to be called the Adjusted Treatment Index, ATI, and you'll be hearing more of that over the next few weeks. And what we've been doing is applying the ATI to various data that we can get our hands on at national level, mostly accounts data, and I'll explain some of that as we go forward, to get some kind of idea of the differences and variances between hospitals across the system. Now, Lord Carter believes there are efficiencies to be made from the work that we've done so far. The work that we have done so far has been more about tightening up, if that's the best way of describing it, management practices and so forth across hospitals. And I'll show you some of the detail in just a second on that. He believes there's probably even greater efficiencies to come from looking at workflow, and particularly the boundaries between trusts and social care. But for now, his main focus has just been purely at looking at the running of a hospital and tightening up some of the management side of that. He's been following the money, so he's been looking at accounts and looking at where the money actually goes and applying the metric to those areas to get a sense of how the money is spent in the system. So the focus has been clearly on workforce, on pharmacy, on estates costs and procurement. And I'm going to go through those in more detail in just a second. The report will contain detail around the Adjusted Treatment Index, how we've arrived at that formula. It has been independently assessed. The independent assessors took the view that it's as good as anything that they've seen around the world, if not better, in terms of sophistication. So we're pretty confident now the index works. And we've been working with a number of trusts, 22 trusts. I'll show you who they are in just a second. And also he's been thinking about the notion of a model hospital. And again, I'm going to come back to that a bit later on because I think that's really important for GS1 adoption. So coming back to following the money, the providers in the NHS take the greatest proportion of the 120 billion health budget, 72 billion. And if you didn't know, the rough split between pay and non-pay across the provider sector in the NHS looks like that. And Lord Carter's view is that unless you address efficiency in the workforce areas, any efficiencies you're looking for in the other areas kind of pales into insignificance. And that's true. Just 1% improvement, if you think about it, 1% improvement in productivity in workforce is worth 400 million. And you'll see that number in his report. When you look at the non-pay side, and you look at the accounts, those are the headings that you see in every trust's accounts, but it doesn't really tell you a lot about what the money's actually being spent on. And again, I'm going to come back to that in more detail. So, at the highest level, we can apply the ATI measure to all operating expenses for each trust. So we know already the total operating expenses per ATI, or the cost per ATI, for every single hospital up and down the NHS. And sure enough, we are finding that there are significant differences between trusts. But there may well be good reason for that. And the only way we can find out what those reasons are is to gather more detail, granular line-by-line detail about the differences between trusts to understand why those differences might be at that level. Okay. The 22 trusts that we've been working with are there. A mix of big teaching hospitals, smaller rural hospitals. We couldn't have split them up more across the country. We've got him travelling all over the place at the moment, but it's geographically spread across the NHS, as you can see. Foundation trusts, non-foundation trusts. We have not yet looked at mental health hospitals. We've just been primarily focused on acute hospitals for now, but that's not to say mental health hospitals will also be looking at those in the coming months. We're adding a further 10 to that initial cohort over the summer. They've not all yet signed up. Most have. But there's another 10 that we'll be looking at in terms of data and information over the next few months. So what we've done, we have sought to collect granular, detailed data from each of the 22 to try and understand some of the issues about why there's differences in each of those areas I've described, of workforce, pharmacy, estates, and procurement. I should say we've also applied the metric to the clinical specialty data that we can get from reference costs, just to triangulate and try and understand some of the relative differences from a clinical specialty as well. But in workforce, what we've done is we collected data and information from a nursing point of view on every ward in every trust for 1 month, their rosters, the hours actually worked by nurses, whether they were agency bank and substantive, and the hours actually paid. And of course that has been enlightening. And again, you'll have seen some of the things that were stated over the weekend in terms of Carter's findings. And of course, what he's finding is that there are significant differences between trusts in the way that workforce is managed. Non-productive time, for example, varies from 22% to 26%. That doesn't sound a lot of difference between trusts, but when I said that 1% is worth 400 million, it is significant. Looked at annual leave, how annual leave is managed, and that's proving very interesting too. Looked at skill mix too, which is highly topical at the moment with NICE's decision last week. But we've also been looking at the differences in skill mix for different types of wards as well. This little chart here is an interesting chart that you'll see in the report, or not this particular chart, but you will see an example of one of the trusts that we've been talking to. So this is 1 month in. This is real data, by the way. I won't say which trust it is, but it's not one of our 22. This was 1 month's data in one ward. Those are the days. The green is substantive staff, the yellow is bank staff, and the red is agency staff. And the blue line is the recommended safe staffing guideline, NICE's guideline, effectively. And what you can see from that, worryingly, some of the weekends there's not enough staff. But equally strange, in the middle of the week, there's more than enough substantive staff, and there's still bank staff, and there's still agency staff on top of that. Now that kind of suggests that workforce management is not as good as it could be. But we need to dig deeper and understand some of the reasons behind that. Okay. The other big areas around pharmacy and estates, I'm not going to spend too much time on these because I really want to get to actually procurement. Pharmacy, collected data again, detailed data from the 22, from the various databases that we can get our hands on, workforce data from the National Electronic Staff Record, and from that we can start to compare trusts with each other around their pharmacy costs and staffing costs. And again, we're finding significant variance. So again, digging deeper, trying to understand why some pharmacy costs in some trusts are higher than others. I think one thing I should say in the pharmacy space is that most pharmacy departments are pretty efficient. So where the efficiencies and savings are, it's lots of little things rather than some sort of big silver bullet. So for example, I'm sure you saw that one in the press over the weekend about the cost of a tablet versus a soluble version, which is massive, it's significant. And in one trust alone, that was worth 40,000, and that's true. That's the data that was taken from the 22. So again, we're investigating more and coming up with more and more examples of those differences to start helping the trusts look at these issues. Estates, a little bit more difficult to compare trusts in their estates costs. And that's because, different sizes of trust, different types of estate, some with older Victorian buildings, some with PFI new build, some with PFI, and so on. But we from the analysis that we've done, bearing in mind there's a pretty strong database already that exists called the ERIC database that all trusts already submit data to. Analysing that tells us that just within our 22, they spend $1 billion, and if the 22 moved up to the average, it would be worth 14% savings across all of them. And if you start to sort of, again, escalate that up to national level, you can see there's significant opportunities in the states area as well. So again, more detailed information, pulling more and more information to understand what those differences are. I just wanted to come onto procurement, because obviously that's where I think where GS1 really comes into its own. None of this is new, but Lord Carter had to go through the process of understanding the state of the nation in terms of procurement, and these are his conclusions. So these weren't mine or the department's, these were his conclusions. That he thinks that procurement across the NHS is highly fragmented. He thinks it's expensive. He thinks that there are significant variations in prices being paid. He thinks that there's a failure to aggregate effectively across the NHS. He absolutely knows now that the data is difficult to come by. He felt that the contract with DHL was weak and wasn't working in the best interests of the NHS. Definitely thinks that inventory management is generally weak, and that systems and controls around that are weak as well. And significant costs of things like sales forces. And there's an example that you'll see there where Leeds installed the RepTrax system to where sales representatives have to sort of book in before they can go on site, and that system has kind of been eye-opening in the data that it's been revealing that in the Leeds Trust itself there's 650 reps on that system, and at any one day there's 65 on site, which is an enormous number. So, I mean, there might be good reason for that. It might be the way we're doing business. But again, these are kind of issues that we're unearthing from the Carter work. I'll come back to the the diagram I put up earlier, we've got a real problem in that we can't get to be able to make a meaningful comparison between trusts around procurement spend. You need to have, first of all, a scope spend that's the same for each trust, that you can apply the ATI metric to get a relative comparison. But then to dig deeper, you need to know the volumes that are bought and the prices being paid. And of course, we just don't have that level of data information. So when we apply the ATI metric, we can only apply it to the accounts headings at this stage. We can't apply it to maybe these categories down here. So for example, what's the medical consumables cost per ATI for each trust, which is what we'd like to get to. And just a anonymised example. These are the 22 trusts. The first column is the non-pay spend for each of the 22 with the ATI metric applied. And so you can see the relative differences between trusts. We can apply it to some of the account settings like the clinical suppliers and services cost per ATI. And again, you can see huge differences. Just look at the top, trust 1 and 2. One is almost twice the cost of the other. But again, there might be good reason for that. It might be a particular type of hospital, kind of stuff that they're using and purchasing. But the ATI metric should actually be taking that into account in terms of its adjustments. But we need that granular detail to understand why those differences are there. What we did do for the 22 to try and get more information and detail is we asked a company called Health Logistics, I'm sure many of you are aware of that organisation, to gather accounts payable and purchase order data from the 22 for the last couple of years. And basically the data confirmed what we already knew, but it's good to have the evidence for this, that there's no common way of analysing either AP or PO data across trusts. There's no common chart of accounts to make that link between procurement data and accounts data. I think it was only around about 18% of the spend could be matched with a PO and invoice, only 18%. And only 15% of trusts have accurate inventory data. The bit of pricing information we could get, but even that is suspect because there's all kinds of discounting and rebating that goes on, so can't trust that either. But even the bit of pricing data we could get, there were significant variances in kind of prices being paid. So basically, this is really difficult in the kind of procurement space if you want to use the ATI efficiency metric. So in conclusion, around procurement, the AP and PO data is incomplete. It's not compatible with accounts information. So how can we do that? We can't determine volumes and pricing, as I've said. So we can't get that consistent data set to make some meaningful comparison between trusts. It does kind of beg the question how trusts manage their non-pay without knowing all of this, quite frankly. So what do we do about it? Well, we're looking at other lines of inquiry, other areas of data information that we can get some leads to try and investigate differences between trusts. So, for example, we could go to the clinical specialties data, so I can get, for example, the non-pay spend for trauma and orthopaedics for each trust and apply the ATI metric to that. And actually that will give us some reasonable lines of inquiry, and we will do that. The bits of data we can get hold of, supply chain data, for example, which does have volumes and prices, albeit knowing that rebating goes on. There's data there we can use, that we can get a sense of how strong the trust has been in rationalising the range of things that are used in the trust. But as you know, the supply chain spend is about 10% of the total non-pay. Or the third thing is maybe we should try and fix the problem. Lord Carter's view is we should fix the problem. He asked me a question about 9 months ago, in fact, why hasn't the NHS got a single NHS electronic catalogue? And it's a good question. Why hasn't the NHS got a single electronic catalogue that all trusts can use? And there's good reasons for it, as we all know. You know, it's a devolved system. Trusts make their own choices. Maybe the technology has not been there where it is now. Or maybe it's just too difficult to do. But we don't. We don't have a single NHS catalogue. But I think things have shifted a little bit in recent weeks. Technology is definitely there. We know that. I think the issue of trusts signing up to such a catalogue being optional is rapidly diminishing because the majority of trusts, as you know, are likely to be in deficit in this financial year, are likely to be seeking financial support from the Department of Health. So it's highly likely signing up to something like this is going to be the way forward. And actually, the big arm's length bodies, NHS England, TDA and Monitor, the chief execs of those organisations all believe that actually trusts should sign up to something like this. It just makes sense when we're in the financial situation we're in the NHS. So I think things are shifting. So to try and answer Lord Carter's question, we are now working on a plan about how you can put in place a single NHS catalogue. Huge connotations around that. You know, how do you get to, you know, the range of products on there? How do you rationalise? How do you get decisions made around all of that? All of those issues are now currently being thought through. But our view is there's no reason why every single product bought by the NHS should not be on a single NHS catalogue. For it to work, though, it needs to be backed up by compliance systems and policies. For it to work, it needs to be backed up by materials management systems. What we don't want is nurses spending time, as they currently do, putting stuff away and counting stock and manually keying in requisitions. So the value of doing this is enormous. It's not just about the volumes used and price, it's about all the other time, the issues of time and productive time for nurses. So we think that the time is right now to look at this. We think we'll look at it in terms of a phased approach. There's absolutely no reason why for basic consumables items, which are non-medical, that you couldn't come up with a list quite quickly. Jeremy Hunt, a year ago now, insisted we have such a I think he called it the core list catalogue, but we're still really no further forward in that. So there's absolutely no reason for the non-medical consumables like office supplies, stationery, those kind of things. There shouldn't just be a list that the NHS should use. And most chief execs that we talk to in trusts wouldn't disagree with that at all. And in fact, it's very interesting that NHS Supply Chain last year rationalised down the range of their stationery lines from about 3,000 to 157, and there's very few trusts that kind of walked away from that rationalised range. So we know it can be done. When you get to the more difficult medical areas, we know it's harder. I tend to look at it in two. There's the stuff where nurses make a decision, and there's the stuff where doctors make a decision. The stuff where doctors make a decision is much, much harder. The stuff where nurses make a decision, actually the nursing community is up for this, and the Royal College of Nursing, I think, have openly already said this at their recent conference. They will happily work on getting to a common catalogue for the NHS around nursing consumables. So we're working on that right now. Doctors, more difficult, and we know there's some behaviours that need to change within the NHS and also on the supplier side. And there's some issues around the kind of policies and compliance that you want to put in place. So we are looking at the kind of things that would help us support a single national catalogue around medical devices, for example. And it does mean we are exploring policies such as, could we look at terms of employment of clinicians? Could we look at implementing a Sunshine Act like they have in the US, where the doctors have to declare and suppliers have to declare interests and so forth. So we're looking at all of those things to try and build some of the compliance and policies around a national catalogue. Next steps for the Carter work. Well, we're continuing to gather detail, as you've seen. So more and more information is coming in. We've expanded the 22 to 32 to take it up to about a quarter of the NHS. There was a line, if you might recall, the issue around the tariff in March, I think, in the little bit of a pickle that Monitor got themselves into, and Simon Stevens stepped in and said that those trusts who wanted to go with the enhanced tariff could do, but he did put a condition on that, and that is that they would sign up with Carter and provide data. We haven't forced that in any way, but that actually is in place with trusts. What has happened over the last 3 weeks since the new administration came in, as that the whole thing has been accelerated. And some of the things that Glenn mentioned now, that trusts signing up to an efficiency number, all trusts that goes into kind of business planning is absolutely now expected from Secretary of State. I still haven't got the foggiest how we're going to do that, I have to say, but that's now the expectation. The thing I do want to kind of focus on now, though, is that one thing that Lord Carter has been keen to do, he's been keen to do this and build this metric, working with trusts, helping and supporting them, engaging them, becoming the experts around using the metric, sharing best practice, so the trusts themselves can see what they need to do, can build their findings into their cost improvement plans themselves. And so he's been quite keen to keep the regulatory bodies away from that activity. Inevitably, what we're seeing is the regulatory bodies now, and who knows what's going to happen in the landscape over the coming months. But increasingly, we're seeing the regulatory bodies wanting to actually influence and shape this. And Lord Carter is reluctant to do that. So what he's come up with is this idea of a model hospital of efficiency. So the idea being that developing a model, a virtual model, for different types of trust, whether it's big teaching or whatever, needs to be developed. The trust then could see good practice, see what they need to do, and the impact it will have on their own measures of efficiency using the ATI metric. And the regulators could use that then to assess trusts against the model. And that's a better way than regulators trying to trust each trust independently in terms of efficiency. You might have also seen over the weekend a move for CQC to assess finance and efficiency as part of their assessments as well. So again, really keen that it's done in a way that is connected to this model hospital. So the notion of a model hospital actually is going to be quite important going forward. So what does all this mean for GS1 adoption? Well, so far from the centre, we've been trying to push things into the system to almost force adoption. So, we've tried to use the commissioning levers to embed it in the NHS standard contract. We've tried to force it on the supply base through the standard terms and conditions for supply of goods and services and so forth. But all of that is push. And I think, and also we've been using patient lever as probably the main reason for doing this. And I think what is now changing is that efficiency now is equally important. And I do believe the notion of a model hospital, because a model hospital, we're having to think about, in terms of a model hospital, what does model procurement and logistics look like? And it would mean real-time data. It would mean GS1. So in building a model hospital, GS1 will have to be at the heart. And that model hospital then becomes the pull for GS1. That's what we believe. And in actual fact, adoption of GS1 helps trusts get to the model hospital more quickly. So that's what we're working on now. And the final thing I wanted to talk about is that we did hint in the eProcurement strategy last year that we felt we needed to help and support the adoption by working with a few trusts to build demonstrator sites to show how to do this, what can be done. So providing the kind of guidance and costs, but also really start to prove the benefits, some of the things that I've been talking about and the impact that then has on efficiencies and patient safety. And people for last year have been saying, show us the money to do this. And it's taken us quite a while to get that off over the line. But I'm pleased to say, was it last week, Owen? Was it last week? We finally got the funding to do this. So we will be funding 6 demonstrator sites over the next few months. And is that guidance published as well, Owen? So that guidance now is being published if people want to kind of apply to be a demonstrator site. So we started the application process. I think all GS1 leads have had a copy of that document, so they're now aware of this. There's the timetable, so not a lot of time to get an application form in. But we need to get on with this, and that's the reason for that. I think we will shortlist down to 12, but we're looking to get to 6 to start adoption in January 2016. I do push the guys, Owen and Steve and others, that the urgency is paramount, and we need to be starting this now, quite honestly, given what I've been saying about the importance now of the efficiency agenda. So I think there'll be some kind of phased approach with it, but we need to get on with it. Is the message. So in conclusion, I'll come back to what I said at the outset. I don't think GS1 now is just a good thing to do. I think it's really, really essential for delivering the efficiencies that I've been talking about over the last half an hour. In some respects, I can't see how you can do it without having GS1 at the heart. So it's really good to see so many people in this room, and I hope you'll go forth and adopt GS1. Thank you. Thank you.